Alright, so we're going to be doing bacterial skin infections. We're going to do algorithms for bacterial skin infections. Start off with the most superficial layer of the skin, which is impetigo. What do I want you to look for in the stem of the question? Right here. Weeping, oozing, honey-colored lesion, okay? It's going to be most probably staph, but it can also be strep pyogenes. Look for topical mupirocin as your treatment, okay? And it's only if it's ineffective are you going to dicloxacillin and cephalexin, okay? Really important thing to know, this is a contagious disease, okay? So it's going to be contagious, and it's going to affect the epidermis, okay? It's affecting our epidermis, and it's going to be contagious. Weeping, oozing, honey-colored lesion, and it's a mild disease, so it's going to be topical mupirocin. If not effective, dicloxacillin, cephalexin. Next, a more deeper layer, right? What are we looking at? The skin between the epidermis and the dermis, all right? And we're going from the epidermis here, and then we're going to this between the epidermis and the dermis for a second one, erysipelas, okay? This patient's usually affected in the facial area. Strep pyogenes is your most common bacteria. And here, it's not as mild, so we're going straight to oral IV dicloxacillin and cephalexin. Now remember, in impetigo, we're going topical first, and if it's not effective, we're going to dicloxacillin. But in erysipelas, it's a deeper layer, it's a little bit worse, we're going oral dicloxacillin and cephalexin. And like we said, it can be strep pyogenes, right? If it's culture positive strep, we go ampicillin. Next, cellulitis. Now we're going superficial all the way down, right? So here, epidermis, impetigo. Erysipelas, between the epidermis and dermis. Next, cellulitis. It affects the dermis and subcutaneous tissue below the dermal epidermal junction, okay? And this patient's going to present with red, tender, warm skin that's swollen, okay? Now we got to worry about sepsis in the cellulitis patient, okay? So if the patient comes in with sepsis, drop in blood pressure, fever, we got to go immediately to IV oxacillin, naphacillin, or cefazolin, okay? Next, folliculitis. Folliculitis, okay? So it's going to affect the areas around the hair follicle. And the area that gets affected is known as a furuncle, okay? And once this joins together and becomes a more focal point, it's going to be known as a carbuncle, okay? So the area around the follicle, the bigger area is known as a furuncle, and then that's the big infected area. And then once it becomes a small focal lesion, it's going to become a carbuncle, okay? It's most commonly caused by staph, and know that if you see whirlpool or hot tub, it's going to be Pseudomonas folliculitis, all right? First step is warm compresses. If it's ineffective, mupirocin, okay? If carbuncles form, which is that focal area that we talked about, IV dicloxacillin. Finally, our worst one is necrotizing fasciitis. Longest word, worst one, all right? It's going to start off with cellulitis, but it's going to dissect downward into the skin. It's life-threatening. Remember that. It's life-threatening. So what are the things that we have to know? Necrotizing fasciitis, life-threatening. Impetigo, contagious, okay? You got to do an X-ray, CT, or MRI, and you're going to see air in the tissue, all right? Increased CK is a very specific finding, and most accurate diagnostic test, surgical debridement, okay? That's our most accurate. However, that's not what we're doing necessarily first. What are we going to do first? We're going to do the X-ray, CT, MRI to show air in the tissue, okay? We're going to start them on empiric ampicillin, sulbactam, or ticarcillin clavulanate, and we're going to do surgical debridement after that.